Finally, we made it to ICP, which is your intracranial pressure. So right now we're going to identify the signs and symptoms of intracranial pressure, as well as some drugs to treat your intracranial pressure, as well as some treatment options, as well as some neurological assessments that we do for your intracranial pressure patients. So, how do we get increased pressure inside your brain itself? Well, this all comes from a traumatic brain injury, basically meaning someone whacks you with a baseball bat, you fall off a building, you get in a car accident, or you can get, let's say, a stroke, a bursted blood vessel, a hemorrhage, an aneurysm in your brain. That could cause increased pressure. Now, the biggest thing is that your skull is still intact, your cranium. Now, I broke down a lot of the pathophysiology of your cranium itself, but pretty much the basics are you have a skull, the outer crust, then you have about 3 other layers that go underneath that called the dura mater, and you have arachnoid matter, then you have the pia mater, and I turn it kind of into a pizza. But underneath all that, you have something called your subarachnoid area. And this is really where the area, it's like the moat between your castle and the rest of the world, okay? It's like the big moat between your brain itself and the crust. So in this empty space, this subarachnoid, this is where your cerebral spinal fluid lives. Your cerebral spinal fluid helps your brain to float, okay? So, if you're really dehydrated, you can have a decreased cerebrospinal fluid, causing that brain to come down and start touching the sides of your skull, causing you to have more headaches. But we're not going to talk about that right now. We're going to talk about increased pressure. So, this increased pressure, most dangerous, is from closed head injuries. Because closed head means that there's nowhere for this increased swelling and this increased pressure to go but down the brainstem, causing herniation. And we know that your brainstem is really the controller for your respiratory rate and a lot of your autonomic nervous system, like your heart rate and your blood pressure. So, there's a lot of stuff we have to understand before we even get into what the heck is ICP. So for ICP, for intracranial pressure itself, basically the cranial contents from your brain tissue to your blood to your cerebral spinal fluid, they're all enclosed inside your cranial crust itself. Now, whenever you have any type of injury, it has little room to expand, like we talked about. So when ICP begins to increase in its cerebral spinal fluid, it's either shunted from the cranial compartment or it's compensated somehow. So if there is a contusion, if you get whacked with a baseball bat and now there's a massive swelling, what's going to happen is your body's going to try to shunt this cerebral spinal fluid into this subarachnoid space. It's almost like playing Tetris. You remember that game? Tetris. And you're trying to organize all these blocks that are coming down at you, and you're trying to make room so that you don't get to the top and then game over, right? So, with intracranial pressure, that's what your body's trying to do. Your body's trying to use a coping mechanism to try to stuff the extra spinal fluid around the brain and compensate for this increasing pressure. Your body's trying to decrease the pressure itself so that the brain can swell a little bit from the traumatic brain injury. Now this is from a contusion. Let's say there's a huge brain bleed and now we have extra volume inside the brain itself. Your body's still going to try to move around this fluid in this moat area, this subarachnoid area, to make room for all this extra fluid. Because when the fluid gets too much, it's going to go down the brain stem and herniate things, causing your autonomic nervous system to be affected, okay? So, let's see here. Your body will try to shunt the cranial fluid into cranial compartments, or it's going to try to increase the rate of absorption of its cerebral spinal fluid, or if it can't do this, it's going to lead to your decreased cerebral perfusion. No oxygen is going to be going or be able to make it to your brain itself. So remember that your body runs on oxygen. If your brain doesn't have any oxygen, it's going to shut down and cause a whole cascade of other events, guys. So let's see here. Let's see. So for some signs and symptoms of your patient, are they getting increased or decreased intracranial pressure? So let's do that here. We have 3 more minutes before we have to cut here. So for your head itself, your patient's going to be complaining of a headache, okay? They're also going to have an altered level of consciousness, ALOC. You're also going to have, possibly from your GI, some nausea and vomiting. Now, I'm not saying that your GI itself is causing the nausea and vomiting, but the traumatic injury inside your brain is so much that it causes you to have sometimes projectile vomiting, which is a direct cause of a brain injury. So I just draw kind of intestines there just to help you remember nausea and vomiting. Don't get mad at me, okay? You can have seizures in your brain itself because you have increased pressure causing these seizures. Obviously, you'll have lethargy and weakness, but your eyes themselves here, you're going to either have pinpoint pupils. That's an early cause. The late phase of your pupils are going to be very dilated, which is called blown pupils. So blown pupils. If your brain itself has a bleed just on one side of it, your pupils will look offset. So one and like this. Actually, that's not an accurate description. But your pupils will be big on the side of bleed. So if I have a bleed over here, my pupil is going to be huge on this side of the bleed. Let me cut the video here and we'll continue the next.